In this video, we are going to talk about cross-linking and its uses in ophthalmology. Now, the first four uses you probably would know. The most common, keratoconus, then pellucid marginal degeneration, Terrien's marginal degeneration, post-refractive ectasia. The next four are the ones which are probably new to you. Infectious keratitis, corneal edema before keratoplasty, and progressive myopia. So let's see how cross-linking is used in the other four conditions. Infectious keratitis. In infectious keratitis, when corneal collagen cross-linking is used, it's got a specific name which is called PACCL, which is photoactivated chromophore for keratitis PAC, corneal collagen cross-linking CXL. In this particular version, we use the accelerated protocol. So UVA is known to cause DNA and RNA damages in the microbes in various organisms. And this combination of riboflavin plus UVA increases the resistance against collagenases in the cornea, and the increased corneal stiffness that in itself resists corneal melting. Now, what are the instances where PAC-CXL is used in infectious keratitis? In bacterial keratitis, there are studies where they've used it against corneal ulcers caused by Staph aureus and Pseudomonas aeruginosa. Now, in fungal keratitis, they've tried it in drug-resistant cases with different kind of results.
This worked only with a higher fluence, meaning 7.2 joules per square centimeter was delivered with 30 milliwatts per square millimeter for a period of 4 minutes.
Because this made sure that there was deeper stromal penetration where the fungal hyphae were present. It's also tried in acanthamoeba keratitis, but here what worked was rose bengal with green light of 523 nanometer rather than riboflavin with UVA light. It has also been tried in viral keratitis. The other use is corneal edema. Now, how does it help in corneal edema? The CXL treatment causes the corneal stiffness to be increased, that we know, which in turn decreases the interfibrillar space between the collagen fibrils. So there is lesser space for fluid accumulation. And we have seen that there is a reduction in the corneal thickness and an increase in corneal transparency. This has been especially useful in corneal edema in case of Fuchs endothelial dystrophy, secondary bullous keratopathy, and in corneal rejection. The other indication is before keratoplasty. Now, how does it help before keratoplasty? It is used to decrease the post-op surgical astigmatism. So what is done is peripheral corneal cross-linking is done, and this prevents keratocyte proliferation. That helps in decreasing the astigmatism, whereas the central donor endothelium is preserved for graft survival. To decrease the recurrence of infection in the graft and also to improve graft survival in high-risk cases where this corneal cross-linking has been proven to decrease corneal neovascularization. The other use has been found in progressive myopia, where rather than corneal cross-linking, scleral cross-linking is done, whereby it increases the biomechanical strength of the sclera and prevents the axial elongation of eyeball and therefore prevents myopia progression. So this has been studied mainly in animals, and a few studies have also been done in humans. So these are the other uses of collagen cross-linking.